Well, I'm sneaking into the internalizing weight stigma. And that's, you know, what everyone says, and so they must be right. The self-focused thoughts on the meaning of people being a person with obesity, you're constantly questioning, am I okay? Can I do this? You're getting things from outside and you're taking it in. So you're never safe when you go into a room. And you get more and more confused about what can you do. And like Ted was talking about this not being there and not being available. So we have, when we're in society as such, we end up with a macro level, which is the policies and planning. Well, you know, people are seeing what can we do and what should we be doing. But it's basic on what we've been talking about, not being fitting into society itself. And then midi-level, which is the specific methods, models, and micro, the individual patient. Usually we talk about the macro level. Usually we put people there because we don't want to get into talking about the individual experience. Neither actually the individual experience of people around us. It's like a friction all the time between, because you don't really want to be, I mean, sorry, you really don't want to be together with that fat girl that Vicky was just talking about. It might be a fat man or boy. And so it affects the individual patient. The ladder, and so, the good old ladder of participation. Policy directs advocating user involvement. We know and we understand and we've learned from other organizations who are fighting what we're doing. We also know that the professional protectionism, what people who are in the profession want to keep us in the profession within the circles, which is really kind of funny because what we need is have plenty places to go to deal with the plenty problems that we have. We go to user consultation to understand, try to get information, and that's why you're sitting here today. You want to ask, you want to know what is it we are experiencing, what we're thinking, what we're lacking, what we want. And looking at the medical model, what is needed and what we can do. Well, then the policy that we're living with is trying to get going and implementing the involvement. We need the support like all the other people with disability. And God knows you're not allowed to call this a disability. But what in the world really are you going to call it? We're not only fat, we're having all the same problems as you do with all the various other problems, physical or mental problems. So we need to sneak in and see what is it we need. I was talking about the fact that you're not accepted where you are. Vicky was talking about the same thing. And who's going to take on helping and supporting us to get space in society? And we have the medical model, that's what David was talking about. We also need a humanistic model. We need people to think in terms of who are we? Not saying, well, I got the group together and we are going to blah, blah, blah. But I, like Ted was saying, principally, what can I do to invite you to my home to feel good with you? Not walk out the door. And that's not only interaction between individuals, it's also within the healthcare system, within the schools, within the education of people getting into work field. So we're all in a circle and touching each other. No, we didn't have that one. We made the Arnstein ladder, have you heard about that? how you bit by bit are stepping up and saying, claiming more a right to be a normal person and getting the services that you need. And help with getting into the various different places where you are. What can you do to the school teacher to realize that you are a clever human being who can do things and not, ooh, well, can't really perform any more than that? What can we do to get the gym teacher to get the kid to be allowed to be there? What can we do to get the national money dividing unit to realize that we might need more money for certain things? And oops, then you get into this thing of being a disabled person. Oopie. We are at sometimes. And then we need services. We need all this kind of services that you need in other places. And that's when it's not okay. I went to a place at one time, and they were giving services to people really smart, but I'm going to let Mary talk about that. But I was having a speech about marginalization of people. How we systematically put them from something that is a normal person, bit by bit, into being something that is taken care of because we have to take care of. On the other hand, folks, there's a lot of positive things going on. Here you're sitting, a whole lot of people, and you're caring. Otherwise, probably you wouldn't be here. Now we can get big clothes. Now we can get all these other positive things so that we can be part of society. So, all in all, we're doing, we could even do better. But that means getting at the pinpoint of where are the knots that keep all this restriction together. And what can we do to keep them?
So let's just see how many people here identify with the patient perspective. How many? Yeah. And how many with the caregiver perspective? Yeah, almost half and half. Wow, fantastic. We're going to have some good discussions here. Thank you. Okay, now let's have a look. Now we have a really global perspective. Jimena with
the Canadian perspective.
Well, I was going to say Chilean, Canadian, Swedish.
Yes.
So, yes, a special welcome.
Thank you very much. So I'm short, so I'm going to lower this. So thank you very much, and I'm going to try to stick to these 10 minutes. And in this session, the purpose is to talk about the consequences of weight bias and stigma. And I think Vicky and Christina did a great job talking about the consequence of stigma on the individual patient. And this presentation is going to be about the consequences of stigma on policy and how it impacts healthcare policy specifically and public health policy. So, going to the next slide, it's not going. There we go. So the Canadian Obesity Network, for those of you who don't know it, but it's not going. There we go. So our vision is to provide evidence-based approaches for obesity prevention and management, and to support policymakers with the evidence required to implement policies. Our mission specifically is to improve the lives of Canadians living with obesity. And we have 3 strategic goals. The first one is addressing the social stigma associated with obesity. And the second one is to change the way policymakers and health professionals approach obesity. And finally, to improve access to evidence-based care. So this is what the network has been doing for the last 10 years. And the way that I conceptualize how weight bias and stigma has influences policies in Canada is to look at this theoretical model. So stigma can operate at the individual level in an overt and direct way when people experience shaming and blaming for their disease, like Christina was talking about, but it can also affect people at the indirect level. So we are socially taught that obesity is self-inflicted, that obesity is not a chronic disease. And so we live in these social stereotypes about obesity that affect people indirectly. But then there are the consequences of stigma at the structural level, at the structural policy level, where our own weight bias attitudes and beliefs, as well as the social stereotypes about obesity, actually influence what policies we have available for Canadians or for individuals living with obesity. So there's been many studies, and this is one model that shows, from Rebecca Poole at the Red Center, that shows how weight bias and stigma can affect individuals' health and well-being, but it can also affect policy and public health policy, specifically in this model. And now we have significant amount of research that shows that experiencing weight bias at the individual level and at the policy level can increase morbidity and mortality at the population level. So what is obesity? In the Canadian Obesity Network, we conceptualize obesity as a chronic disease. It's a progressive chronic disease characterized by abnormal excessive fat accumulation that impairs health. And we know from the evidence that it is associated with medical conditions such as diabetes and other specific conditions. But we also recognize that weight bias is an independent factor that impairs individuals living with obesity. So beyond any physical and mental or social impairment that they have because of their weight or their disease, they also experience weight bias, and that also impacts their health and well-being. So we recognize that weight bias is an important issue. And as we know, we've been talking about obesity as a chronic disease for decades. WHO recognized obesity as a chronic disease in 1948 when it was first established. Yet the narrative that Ted was talking about is not of a chronic disease narrative. The narrative is this is a self-inflicted choice. And so in the Canadian Obesity Network, we've been trying to raise awareness and to educate and develop primary care tools to influence practice and behaviors and policies to implement the conceptualization of obesity as a chronic disease as opposed to a self-inflicted choice. And so these are our 5 principles that we live by at the Canadian Obesity Network, that obesity is a chronic disease. Obesity management is not about reducing the numbers on the scale solely, it's about improving the health and well-being of individuals. And that, weight management and obesity management is about helping individuals address their own individual roadblocks, and that success is different from person to person. We all come in different sizes and shapes, and that not everybody's best ideal weight, it may be the best way for a person. So we don't work towards the numbers on the scale necessarily. So I looked at the public health policy narrative in Canada, and when I looked at all these obesity policies in the Canadian system, all of these narratives ignore and do not talk about obesity as a chronic disease. They talk about obesity as a lifestyle risk factor, a risk factor for other chronic diseases that are very serious. And so every province and every territory in the country has a policy for obesity, but they do not talk about obesity as a chronic disease. They talk about it as a self-inflicted risk factor that we need to prevent through healthy eating and exercise. And that is the primary narrative, which Ted talked about a little bit in his research. And specifically what I found that these strategies are very focused on the individual. Let's tell the individual to eat healthy and to exercise more, because that's going to prevent and reduce obesity. We also saw that these policies have had very modest effects in reducing obesity at the population level, and that there is a very heavy focus on just reducing weight and not the overall holistic aspect of health of the individual. And of course, this excessive preoccupation with weight has led to, focusing on body size as opposed to health and well-being. So a lot of the prevention policies we have in Canada have outcomes such as let's reduce the BMI at the population level as opposed to let's improve the health of the population. So the reactions when I talk to patients with obesity living in Canada, I ask them, what do you think about these policies? And the reaction was, these messages are overly simplistic and do not represent their realities. And the public health messages tend to shame and blame individuals for their own obesity, and it tends to quantify health in terms of numbers, BMI versus weight, as opposed to health and well-being. So when I talked to them about, okay, why do you think this is? Why do we have this narrative in Canada? Ultimately, what patients said to me was that there is a complete lack of understanding of obesity in the professional community, in the policy community, and that this impacts their experiences of weight bias. This also impacts what Christina was talking about, their self-understanding and how they conceptualize themselves. So when they hear from people living from the public and policymakers that this is a self-inflicted disease, they will internalize those messages and believe this is their fault. That can produce an emotional response and behavioral response from patients. So many patients talked about feeling depressed and anxious, not wanting to be outside, not being able to socialize with other people, and also take very harsh responses such as, suicidal thoughts, or even attempting suicide because they don't fit. And so when I talked to the patients, we talked about, okay, how do we fix this? And a lot of them talked about the recovery process of trying to deal with the fact that this is a chronic disease. This is not a self-inflicted choice, and that was helpful for them to be able to move on. So when we did this at the Canadian Obesity Network, we said, okay, so the narrative in Canada is that obesity is a self-inflicted choice. And then we went and we did an environmental scan to see how much access is there to evidence-based treatments in Canada. And these are the treatments that are evidence-based that are listed in our clinical practice guidelines in Canada. And what we found in our report card in 2017 is that none of the governments, federal, provincial, or territorial, recognize obesity as a chronic disease. Health Canada does not consider obesity a chronic disease. And Health Canada is a body that adopts and accepts and approves evidence-based treatments, and they don't recognize obesity as a disease. The Senate and the politicians don't consider obesity a chronic disease, and even insurance companies and private health benefit plans do not consider obesity as a disease. The impact of this is that health professionals are not being trained on obesity as a chronic disease. There are now a little bit over 60 physicians in the country who have been trained and certified as obesity certified physicians. In a country where we have like 60,000 physicians, 60 of them have obesity training. We know that the system tends to tell people, yeah, this is about diet and exercise, so the most allocated resource for obesity treatment is dietitian services. There's low access to exercise professionals, and there's definitely almost zero access to mental health support for people living with obesity, and significant gaps in access to interdisciplinary care. So we scored every province. We also found out that Health Canada, who has approved 2 medications, now 3 medications are available in the market. None of these medications are covered by either provincial or federal health plans or private insurance companies, very low access. So they all got an F. And in the private access, less than 20% of the Canadian population who has access to private benefit plans actually has coverage for these medications. So it's basically inaccessible. Surgery, on average, 1 in 1,883 patients have access to bariatric surgery in Canada, and the disparities between provinces is huge. So you can be in Alberta and have 1 in 300 people having access in 1 year, versus in Nova Scotia, 1 in 1,312 patients having access to surgery. So again, the provinces, the wait times for surgery can range from 6 months to 5 years. That also got the provinces an F. And in conclusion, we determined that the lack of access to bariatric surgery and lack of access to evidence-based treatments basically means that people are dying waiting to receive treatment for obesity, right? So this is a direct consequence of the obesity narrative we have in Canada and the weight bias attitudes and beliefs that we have in Canada, in my opinion. So we have called the governments to treat obesity as a chronic disease, to reduce weight bias and stigma. We've called for private and public payers to provide access to evidence-based treatments, to increase training for health professionals, and to build capacity for interdisciplinary care for obesity management in Canada, and to implement new clinical practice guidelines. So thank you very much for that. I hope I said much.
And it's time to hear from your neighbor to the south, from the US. Joe, welcome.
So I'm Joe Naglowski from the US, from the Obesity Action Coalition. Honored to be here. These are my disclosures. Don't have any personal disclosures. I will say I do have biases though, because I am from the Obesity Action Coalition. I have my own lived experience with obesity, as well as been shared many experiences by our members, and so that does bias my thoughts in some way, so just keep that in mind. So I've really been asked to talk about weight bias and policy in the US, and I'll just be frank, I mean, everything we do is impacted by bias, whether it's research, access, prevention, or treatment. Weight-based discrimination remains legal in most situations in the US. Coverage of obesity care is limited, as Jimena shared in Canada, is similar in the US. Kind of this idea that punitive efforts to penalize people because of their weight are often proposed, whether that's by our key elected officials or through the people who pay for our health insurance in the US, which is usually your employer or an insurance company. Oversimplification of obesity is often reflected in policy efforts, and I think we saw that, Jimena pointed that out in Canada as well, so it's not unique in the US. And then our investment in research is also pretty small. So I'm gonna highlight a couple of these, and I'm only gonna talk about, obviously this is the challenges with stigma, what's going on right now. Later on I'll talk about some of the solutions we have, but to start off with the problems. So when it comes to weight-based discrimination, so US law does not include obesity as a protected class. The way I heard this described at a meeting from our own Centers for Disease Control was that an employer could decide to fire every employee whose BMI was above a certain level in the US, and it would be perfectly legal for them to do so. There is one state that makes that illegal, and that is Michigan, which has a law making employment-based discrimination illegal. Just keep in mind, it's just employment-based, so that means, for example, as a landlord could choose to not rent you an apartment because of your size, or a store could not serve you because of your size, and that is still perfectly legal. People often point out to me, well, we heard obesity as a disability mentioned earlier, what about the disability laws in the US? And the results have been pretty mixed. Our own Equal Employment Opportunity Commission and some courts have found that if you have severe obesity, that does qualify as a disability. There's an interesting requirement of that, though. You actually have to be able to demonstrate a physiological cause of your obesity for it to be considered a disability. And it's an interesting argument, and actually OEC is participating in a amicus brief filing in our own appellate court system right now, trying to have that overturned and just say simply reality is obesity is a disease. Not everyone who has obesity has a disability, but some may, and therefore let's not exclude them by requiring some level of documentation that's not required for any other disease. And frankly, you can see this data here. This is Rebecca Poole's data, who we've mentioned a lot today. But for example, if you are a woman, the most likely reason you're going to be discriminated against is because of your gender. But the second most likely reason is because of your weight. And this is work that she did many years ago, and here's that data broken down in a different way, just so you can see how soon and how often it happens. So women with severe obesity, BMIs above 40, those chances of discrimination are approaching close to 50%. And there's lots of other data around this in the employment setting, and we don't have time to talk about that today, but we even know that women who have obesity earn about 15% less on average in the US than their normal weight counterparts. We definitely see women being more vulnerable to weight discrimination. The other area that we see bias rearing its head is around coverage of obesity care, and very similar to what you saw in Canada, obesity coverage is lacking. Bariatric surgery is the best covered in the US. However, there are barriers put in front of people, and I'll show you a quote about that in a second, making it harder for people. Say, I guess about 70% of people have access to bariatric surgery in the US. Now, it doesn't mean that only 1% of people utilize the benefit, but it is much more common coverage. With that being said, I will tell you, for no amount of money can I buy coverage for the employees of the Obesity Action Coalition for obesity care. As a small employer, and remember in the US system, as a small employer, you buy insurance for your employees. That service, that benefit is not offered to me. I cannot find an insurance company to do that, and that's been a challenge, and it is a challenge to many small businesses. I'll also point out that counseling is supposed to be covered actually under the Affordable Care Act, more commonly referred to now as Obamacare. Everyone is supposed to have coverage for counseling for obesity. However, that provision was never enforced under the Obama administration, and now not enforced under the Trump administration. So while it exists in law, it exists in law only, and there's no practical use of that, or very limited practical use. And of course, pharmacotherapy is as limited as well, and it's something I struggle with personally because I use pharmacotherapy and I have to pay for that out of pocket. bias really does drive this lack of coverage, and I won't cover both of these quotes. You can read them there, but I think the first one points out the message I said about bariatric surgery earlier. This is a gentleman from a large insurer who basically said, fortunately, we have enough hurdles for those obese people that few of them make it through to get bariatric surgery. We don't need to be spending all that money on surgery and drugs when exercise works so well. And obviously you see bias rearing its head there as well. And then you see the second comment about medication use and this interesting idea that, well, they're just going to regain their weight when they stop taking medications. And yes, people's blood pressure goes back up after they stop taking their blood pressure medicine as well, but we're okay with them taking blood pressure medicine for a long period of time. We see all kinds of policies that are really about penalizing people. Again, this blame and shame that's been pointed out previously. And yes, that is real on the top right-hand side there, where the state of Mississippi actually, someone in the state actually introduced legislation to ban people with obesity in the state from dining in restaurants. That was actually a real piece of legislation that a legislator did. Interestingly, the legislator who did it lived with obesity. And when we made national news on morning television and we were to debate that, he said he did it to gain attention around the topic. And I talked to him about there are much better ways than stigma and bias to gain attention around this topic. And luckily, the news reporter took him on in a very significant way, so I didn't have to be the bad guy. I could be the guy coming back with more appropriate solutions. But the reality is I don't think a day goes by that we don't see a penalty-based proposal. And again, in the US, where your employer pays for your insurance, employers are the ones who are often implementing these penalties as well, because they say your insurance is more expensive if you have obesity. Even though it doesn't cover obesity, your insurance is more expensive. The other issue, and I think this has been mentioned as well, is this idea of us conflating prevention and treatment. They really are not the same thing. And don't get me wrong, you're not going to meet someone who is a bigger advocate for making the healthy choice the easy choice. However, just making the healthy choice the easy choice for me is not necessarily a treatment for my obesity. They're not the same thing. And we see that quite often throughout all of our efforts, where we can get policymakers to think about prevention, but they're just not so interested in helping us with treatment, not helping those who already live with the disease of obesity. And of course, research is infected as well. So I wanted to just point out some of this data. So our own National Institute of Health, which funds about $32 billion a year in research, only 2% of that money goes to obesity research. About $800 million US dollars. And even though the obesity rate is 40% in our country. And frankly, if we look at the proposal for 2018, although we're already in it, everyone knows the US budget system is always crazy and they're fighting how they spend money throughout the year, but it looks like about a $200 million cut, more than 20%. And I know you're not going to be able to actually see all these things that it's not, but on the list of conditions that our research funds, and a lot of these are categorized into groups, but obesity is 51st on the list of conditions that are actually we fund research for. So we're number 51 on the list, even though it again is 40% of the population. And you can see the significant investments there. So we don't spend nearly enough dollars to try to impact obesity considering its prevalence. And I think that is bias-based as well. I didn't want to have everything be negative when I talk, so I just want to talk about a couple policy efforts. There is actually legislation in one of our states trying to take on this discrimination policies, making it illegal to discriminate. There's legislation called the Treat and Reduce Obesity Act that's trying to improve access to treatments. And then there are efforts nationally that I'll talk more about later that are about trying to change public perceptions, and that's our National Obesity Care Week resolution. So I'll end with this. U.S. policy efforts to curb obesity have in many cases stigmatized and in some cases outright discriminated against people with obesity. Policy efforts can play an important role in addressing obesity, but recognition that some efforts have caused a great deal of harm is lacking. And I think that's a real important issue, that much of what we've done has done more harm than good. And then of course, obesity is bad, not the people who live with obesity. Thank you very much.
I'd just like to ask before we take the coffee break, does anybody have any questions for clarification for any of the speakers we've heard so far? Is there something that is unclear that you'd like to have clarified? Yes, please. Please state your name.
My name is Rami El-Husseini. I'm from Beirut. I'm a dietitian and I'm at the American University of Beirut. I had just two small questions. When you said it's regarding the discrimination laws, doesn't discrimination cover against physical appearance? Because technically, if we consider that obesity is not a disease, but it's obvious because we see it. But discrimination does prevent someone from discriminating against me because of my physical appearance.
Not the way the interpretation is. There's certain aspects of it. For example, your race may, or your ethnicity may, the law is specific about that.
Okay, so they specify that physical
right.
appearance means race. It doesn't mean if I'm ugly, because
Right,
some people
right.
are discriminated against because they're ugly.
Yeah.
Right.
The Canadian
The law
Human
protects
Rights
them.
Act doesn't have size or weight as a protected area.
How about ugly?
No,
No.
They can fire me
No.
because I'm ugly?
no. Physical appearance is not, like even like tattoos, nothing like that it's not protected. Just physical appearance is not. The disability is protected, but obesity is not considered a disability in Canada, so.
Right. In the same in the US.
Yeah.
Also.